Muhammad Ilyas. He's in pediatric nephrologist. He is in the University of Arkansas. So welcome, Ilyas. Thanks for joining.
Thank you, Aves. Thanks a lot.
Welcome. Okay, so let's start with the brief introduction. So also just to remind, please mute yourself when you're not talking, so there won't be any background noise. So let's start with Dr. Rabia. Please introduce yourself. Briefly.
Assalamualaikum. Can you guys hear me? Okay, Assalamualaikum. I'm Rabia Azmat, and I'm a consultant nephrologist at Al University Hospital. So I've been practicing there at the university for like last 4 years, I believe. Yeah.
Good.
Yeah.
Irshad Ali, welcome.
Assalamu alaikum everyone. I am Dr. Irshad Ali, working as assistant professor pediatric nephrology SIUT.
Very nice. Dr. Umair or Brigadier Umair Siddiq, right? Is he here? Okay, that's fine. Maybe we'll join later. Ahad Qayyum, Dr. Qayyum, you are here?
Ji sir. So my name is Ahad Qayyum. I am a consultant nephrologist in Lahore. Yeah, and it seems कि मैं रेलू कटा हूँ क्योंकि हर टीम से होता हूँ.
Okay, I think you have Dr. Rame, right?
That brings back memory. I haven't heard that word in a long time. That's not that.
Yeah, that's exactly. There's no like, you cannot translate that in any other language. Maybe my vocabulary is not that great.
May I suggest jack of all trades? He is jack of all trades.
Oh, Mazani. Okay, you're right. Okay, so Dr. Rame, you're here. Okay, maybe he'll join later. Dr. Ilahi. Okay, anyway, maybe he will join later. Okay, so let's start. Basically, it'd be more like a discussion forum rather than any lecture or anything. I sent everybody some slides from my previous talk that I gave about a year ago in a hypertension conference. So I hope you quickly, went through that. So basically, hypertensive emergencies, we're talking about patients who are admitted to hospital and who have high blood pressure, most likely systolic blood pressure, most of the time more than 180, or diastolic blood pressure more than 110 at least. And they have some signs of end organ damage, right? CNS or cardiovascular or renal or any other. So those are what we call hypertensive emergencies. If blood pressure is the same range, but patient does not have any signs or impending any end organ damage, so that called hypertensive urgencies. So there has been many terms in the past, malignant hypertension or hypertension crisis, things like this. So basically trying to simplify that, now we use only these two terms, hypertensive emergencies or hypertensive urgencies, those conditions. So basically we're going to talk about a little bit of the medication. We use the IV medication for blood pressure control. So I know in Pakistan, there are limited numbers of medication available. We'll talk about those medication. But at the same time, this is an academic talk. So we will talk about a little bit those medication which are not used in Pakistan, but being used all over the world. So Ahad, can you just tell me what other medication you are using in your hospital, IV medication for blood pressure?
Right. So for patients which we are managing in the emergency room who are coming with for hypertensive urgencies or emergencies, the thing that is mostly used usually is nitrate. So isokit is the one that is most predominantly used in the ER. Whether it's in agreement or not, but that is the most prevalent one that we see, at least in Punjab. That is the one that is being used. IV is easily available. IV Lopressor is also available. Apart from it, I think these are the three main ones which are there. IV sodium nitroprusside can be made available, but I don't think it is easily available anywhere. So usually what happens is that before we hit the floor or the nephrologist is called, usually the patient is already started on an IV isokit drip. Apart from that, usually IV hydralazine, and as I said, I think beta blockers are the one that is available. Apart from that, I think my other colleagues may contribute to it, but to the best of my knowledge, those are the ones that are predominantly used.
Okay, so you mentioned nitroglycerin, right? That's nitroglycerin, and labetalol and hydralazine. Any other IV medication for blood pressure available? Dr. Abia, you are Khan, any other medication available there?
Yeah, we have IV labetalol along with that. So we usually use IV labetalol unless there's a contraindication to it. So that's the first line that's being used right away, followed by hydralazine and nitroglycerin in terms if when the patient has pulmonary edema or associated ACS or something. Otherwise, it's primarily labetalol, the first line that's used.
Okay, Dr. Irshad, I mean, you are also in Karachi. I mean, you have nitroprusside available there in your unit? You use that?
No. We don't have nitroprusside. We have labetalol. That's the first choice, and then IV hydralazine. That's it. 2 drugs. Same as most of the country. Nitroprusside, I heard it's available in Karachi, especially AKUH, and Dr. Rabia is working there. So I was in contact with pediatric intensive care team there. They use it in cardiac intensive care, basically post-op coarctation patient. So I have confirmed it as well recently. So in our setup SIT, we have just labetalol and IV hydralazine.
Anyone from UK here, or other than Pakistan or USA? Or I'm just wondering that what is available there, what use it there. Okay, so these are medications to talk about just for sake of, what we use here. I mean, also depends on USA, depends on the availability also. Slight difference. So please mute yourself if you're not talking, so because there's some background noise. So, and tell me that what we use in our institute is the most common one, which is clevidapine. I don't know whether you're using or not. Dr. Farooq, use clevidapine or you don't?
Which one is that? I mean, like, do you have the other name? I have seen it sometime. Neurosurgery has used that, but I think
okay, that's a
Nicardipine.
Yeah, actually, it's a next generation of Nicardipine. It's pretty much same calcium channel blocker.
Yeah, I have seen sometime neurosurgical ICU, they have used that. So we have this available.
Okay, good. Irfan, about you, I mean, you have any, Dr. Awa?
We're using Nicardipine only.
Okay, anyway, so basically, I think common used medication in the USA is Nicardipine. It's a calcium channel blocker, right? It has pretty safe and very commonly used, and it's not very expensive, and it's there for a long time. I think in Pakistan, people should work on that. Why it's not available, and they should, because this is pretty safe and pretty much used in all the condition. Maybe with a few exceptions, Nicardipine is very safe and very effective medication. So clevidapine is a new generation. It's more short acting as compared to Nicardipine, and it's here. It took me some time to get it, approved in our hospital. Since we've done that, this is our first choice. And then obviously we use labetalol quite often, very commonly used, and we use. Have not used nitroprusside for a long time. Omar, are you using nitroprusside, or I doubt it?
Again, I think with Nicardipine and these drugs, the nitroprusside has gone down. I think we have to check some levels for some toxicity, right?
Exactly.
For cyanide or something. So
I personally have not used for more than a decade. I mean, at this time, we have not using it because of its multiple potential side effects, and better medications available now. And so other medication we use here is a beta blocker like labetalol and ismalol, because short acting, and ACE inhibitor like enalaprilate we use. So in different conditions, we use different medications. So let's talk about what is available in Pakistan. And first of all, let's talk about what are the hypertensive emergencies condition we face and what are the target blood pressure we should have. So let's talk about first CNS hypertensive emergencies. So we see patients who come with severe, like a stroke, ischemic stroke, and normally they have, many of them, they have very high blood pressure. So in that case, the target blood pressure, anybody want to comment that what target blood pressure should be on patient presented with ischemic stroke?
150 by 90.
Yeah, I guess it should be about 220 by 120, no less. If it's higher than that, and so you initially don't really do anything, because that's where the cerebral perfusion pressure comes from. So it's the intracranial pressure and the systemic pressure difference. So you need to have good perfusion to prevent that. Yeah.
Absolutely. Sometimes you forget that. Sometimes you get panic that, okay, patient has blood pressure of 210 or 110. We need to do something. But if that patient is coming from ischemic and patient is not a candidate for TPA, you don't need to do anything, at least in first 24 hours. If blood pressure is more than 220 or more than 110 diastolic, in that case, you can bring down slowly to slightly, but otherwise you don't need to do anything worse if you try to bring the blood pressure down, at least in first 24 hours. Obviously, if patient is a candidate for TPA, then you need to bring the blood pressure down to at least 180 systolic and diastolic 105 in this range. So different CNS emergencies requires a different target blood pressure. So now the next one is like when patient has ischemic intracerebral hemorrhage. So in that case, your target level is a bit low, a lot low, because you can have expansion of hematoma if your blood pressure is not lower. If you keep it high blood pressure, then you can have expansion of hematoma. So in that case, your target blood pressure is systolic blood pressure about 140. In this range, you need to bring it down. And the third is CNS condition, which we see when there is a subignite hemorrhage, which happens when there is a bleeding or ruptured cerebral aneurysm. So there is a slight difference between the target blood pressure when you have a subignite hemorrhage as compared to intracerebral hemorrhage. The reason being that when you have a bleeding aneurysm, cerebral aneurysm, that spills the blood most in a broader area in the cerebrum, and that spilling the blood, actually that triggers a vasospasmic action response, and that can cause a vasospasm in the wide area of cerebrum. So in that case, to prevent that, you need to keep the blood pressure a bit high. So
and I'm not sure. Oh,
okay, so around systolic blood pressure around 160. So if you have a patient already treated with this, like clipping of aneurysm, then you can have even higher 160. Because if you lower the blood pressure, you can have vasospasm, cerebral vasospasm. And so that need to be prevented. Any comment on that? Any on this target blood pressure at intracerebral hematoma or subignite hemorrhage? I think at least everywhere, Pakistan neurosurgery is pretty common, and they're good department in Pakistan, neurosurgical, all the big hospitals, right? If I'm not wrong. I mean, I know Lahore General Hospital has a good neurosurgery center.
Yeah, so Lahore General Hospital and lots of hospitals in Pakistan are doing quite a lot of neurosurgical consults. The thing that we discussed on the forum also was that whether they would call a nephrologist to deal with such matters. Usually, that is a main concern. I think Dr. Aurangzeb is here, who is I think the head of department at Lahore General Hospital. Probably they do call him, but more often than not, I think the medics usually handle it. Just a sort of comment on this is that, as I said, usually they use IsoKit, but before IsoKit is started, they usually put sublingual, this captopril, they usually use that more often than anything else. So that is a drug that they're using. But of course, I'm not sort of advocating that whether a medic should be there or not, but nephrologists are rarely called for these emergencies. Only when they are unable to do anything that they call us.
Is Dr. Naveed? Okay, so cardiac emergencies with very high blood pressure, which one of them is like you have congestive heart failure. I'll go like quickly because we went through already, and then we can have renal emergencies, can have acute kidney injury, and so basically these are one important thing. Emergency CNS wise is hypertensive encephalopathy. When patient comes with very high blood pressure, and patient has headache or confusion, and could be ataxia also, and there is no focal sign, there is no hemorrhage, so it's not a CVA, just very high blood pressure, compromising with some area of the circulation or edema cause that. So let's talk about the blood pressure medication available in Pakistan. So most common blood pressure medication, I'm sure you folks are using, must be labetalol, right?
Are we talking about IV?
IV, yeah, only IV.
Only IV right now. Yeah, so in Karachi so far, yeah, we have IV labetalol, that's most commonly used, followed by IV hydralazine, of course. But then a lot of institutions are also using IV nitroglycerine, which is isocate, of course. So, and that again, as Dr. had mentioned a while ago, that most of the time the ED tends to start off with the antihypertensive medication before them, and the nephrologist record in. So that's somehow a knee-jerk reflex from their end, that they tend to start patients off right away with nitronine isocate, which is nitroglycerine. However, in my hospital, somehow we incline more towards the labetalol. But then on general terms, yes, nitroglycerine is more commonly used.
Okay, thanks for clearing that, because I thought isocate. So isocate is nitroglycerine, right?
Yeah.
Okay.
Yeah.
Not sure. So there's isocate and hydralazine. So basically, so labetalol seems to be one of the common one. Labetalol is basically works pretty much in every condition, except a few exceptions when patient has bradycardia or patient has a bad bronchospasm. So you use labetalol as infusion or boluses most of the time?
Well, in our setting, we tend to use infusion rather than boluses, because that's easier to use, because, with a lot of patients being managed simultaneously, so it's easier for the nursing to do it as well, and a better monitor of the drug blood pressure as well simultaneously. So we use infusion primarily.
Yeah, so labetalol most commonly used as infusion in hypertensive emergencies. As a nephrologist, sometimes my concern is that, I don't know, Dr. Omar and Dr. Endure, when we give in ICU, when you give labetalol, it takes a lot of fluid to be given with infusion. Even with concentrated, I always have problem with that. Like if patient is getting 1 milligram per minute, which is a kind of lower dose, patient need to be at 25 cc per hour fluid. So common use is 2 milligram per minute, and that means that 50 cc an hour of the fluid patient is getting. If it goes to 3 milligram, which is kind of high, but so 75 cc an hour patient is getting, and some patient cannot tolerate that much fluid with medication. And even with the Nicardipine, you give a lot of fluid with medication. That's why Nicardipine is my favorite, because you give hardly any fluid with that medication also. One of the benefits of the new medication, Nicardipine. So labetalol basically is a beta blocker. I know it has both alpha blocker and beta blocker capacity, but actually it's the ratio of alpha blockage and beta blockage is also a bit different when you have oral. And, anybody want to comment on that? Any idea that the ratio, how it's changed when changing from PO to IV? Let me see any questions meanwhile.
So do baatein, I think Dr. Zishad Ahmed Chatta has is absolutely right in pointing out that isokit is actually isosorbide. It's not GTN. So GTN is available as nitronol. So isokit is not GTN. It is isosorbide actually. And I think he's writing it in the text box. So I just wanted to highlight that thing.
No, okay, thank you. Thank you.
Yeah, and the second thing that I wanted to sort of put you on the spot was that am I right in saying that the first drug जो भी अब available है 3-4 के अंदर से, would you sort of say कि जी पहले हमें labetalol use करनी चाहिए या it's too soon to say right now या हम एक-एक करके कर रहे हैं?
Labetalol is a safe and effective drug, and I think it works pretty much in every condition, except a few ones. I mean, I told you that. So I think your first choice should be labetalol, I guess. I mean, Umar, what do you think?
I think like I was typing the question as well, the side effect profile and some of the other things. So if patient is already bradycardic, which you probably are not going to see in this population very often, so that's not a limitation. So I think if I have to choose between these two drugs, nitrates versus labetalol, I would go with labetalol, because headaches that are associated with the any form of nitrates, they are bad. So I'm not sure. So I was typing a question. It's like how commonly do you see headaches as the side effect?
Let me comment on that. Basically, it's the same thing as isosorbide, it's nitroglycerin. If basically it's a venodilator, it lowers the blood pressure at higher dose. When the higher dose, then it's called arterial dilator. And if you don't have headache, you don't have enough dose. I mean, basically you have to have increased dose to improve, to lower the blood pressure, arterial vasodilator. And so at that dose, pretty much everybody will have headache. Otherwise, dose is not enough and the blood pressure will not be effective. That's definitely. Irfan, any comment on those? I mean, what your choice would be if you have these availability of the medications? What medication would be?
Between the two, I would also pick up beta blocker.
I hear clearly. Yeah, I mean, any other folks, any comment on that? I think I would go for labetalol first, unless there's a contraindication like bradycardia or very severe bronchospasm. That's the only two reasons. Otherwise, it works pretty much in every scenario. So let me check any questions.
Well, Wes, as you mentioned, the alpha beta ratio, the beta ratio, I think, is more with the IV administration. So in terms of pheochromocytoma, I think you need to first make sure that you have a good blockade, and then use it.
Absolutely. This is a very important thing, because this is a labetalol we know that it's both alpha blocker and beta blocker. But when you have ratio is a bit different when you have oral and IV. The oral ratio is 1:3, like 1 alpha blockage and 3 times the beta blocker. But when you go to infusion, it's 1:7. So basically it's a very little alpha blockage in infusion as compared to, it's mainly as a beta blocker. So when you have a condition like a pheochromocytoma or cocaine or any discharge, sympathetic discharge condition, you make sure that you don't start labetalol, just labetalol, and you have to make sure that you have medications to keep the alpha blockage also. Actually, if we go by previous studies about 15 years ago, if a patient had come with a cocaine toxicity, the drug of choice was labetalol IV. But then they realized that it does not block alpha receptors enough, so there's not a choice. So if you go recently, relatively recent, 10, 15 years, that's not a drug of choice in those conditions, labetalol. So very important point. Thanks for making that. So second, we can go back to, which is a medication very commonly used, like that is isosorb, or that also is commonly used, and basically it's not very effective, I think, as compared to nitroprusside. But this medication is safe, hardly any side effects, just other than headache. And particularly in some condition, it works very nicely, particularly cardiac condition when patient has congestive heart failure because of very high blood pressure or coronary ischemia. That is very effective medication. But at the same time, there's some drawback about this medication. It has a tachyphylaxis effect, like after long use, after a day or two infusion, is the potency decreases. So that's the other thing. Otherwise, and it's not very potent, that takes time before it starts working, and you have to give high dose to be effective. And the third medication is hydralazine. Hydralazine, basically, nobody ever used hydralazine infusion. Have you, anybody, ever?
No.
Yes, it's commonly used here, you know, patients with preeclampsia.
Mm-hmm.
And the gynecologists are very fond of starting hydralazine infusions here.
They start infusion? They use infusion also, hydralazine infusion? Interesting. Because
IV boluses and then infusion.
I never saw anybody using a hydralazine infusion. Actually, I Google searched that. Anybody use that? Any study on that? The only study I could find the comparison between hydralazine boluses and hydralazine infusion. One study was from study. They found out that hydralazine bolus is more effective than hydralazine infusion. So, but I don't think that I ever used hydralazine infusion, but obviously I have no experience, and so that's for hydralazine. So if a patient has preeclampsia condition, what would you do first, labetalol or hydralazine? The patient needs IV infusion medication for in preeclampsia. So these two drugs are used, and labetalol and hydralazine both are commonly used. So again, in US at least, the tendency is to be labetalol as the first choice.
Well, labetalol IV is not available in Pakistan. I mean, at least in Lahore and these areas, and very rarely available. So we're short of it. So hydralazine is the only choice, or magnesium sulfate to start with.
Again, in Islamabad, IV labetalol is very much available in most tertiary care hospitals. So we use it quite often. Maman.
Okay, I thought the labetalol is very commonly available in Pakistan everywhere. Yeah, if you don't have choice, then hydralazine is where to go. But okay, so I mean, this is very limited choice. I mean, I think somebody should do something about those. I mean, there are some medications which are available all over the world, which are not very expensive medication. They are not very new medications, not fancy medication. Like Nicardipine. Nicardipine is such a wonderful drug. I mean, it's such a safe drug and works in everything, almost every condition. It's hard to imagine that it's not available in Pakistan.
And there may be an opportunity here now with clovidipine coming out. Most of the US ICUs are going to start shifting over to clovidipine. So nifedipine is going to be looking for not nifedipine, Nicardipine is going to be looking for newer markets. I think this is a good time to reach out to someone who can start marketing Nicardipine in Pakistan, because it's very easy to use and it's a very safe drug.
Very safe drug, very effective, very easy to, hardly any side effects. No, you don't have to renal failure or hepatic failure. You don't have to adjust the dose. So it's a wonderful drug. I mean, so there's, I mean.
Yeah, Awais, is nimodipine pretty similar to the way it works, or you just use it for subarachnoid hemorrhage, or because nimodipine as nemotop is available in Islamabad? Nimodipine.
So nimodipine basically is not an antihypertensive medication. It works only receptors in CNS, and it only works in some receptors in cerebral perfusion and even to prevent vasospasm in patient with subductal hemorrhage. So in exam also, you can say this is not an antihypertensive medication. It doesn't work as a blood pressure.
More for that, yeah. Okay.
Okay.
May I, Dr. Wes? You're saying that someone should do something about bringing these drugs. I actually have tried doing this because my younger brother works for a multinational pharmaceutical here, and he has connections everywhere. So I suggested this to him that, if they could bring in an imported drug. The problem is with the federal authority, DREP, the Drug Regulatory Authority of Pakistan, to get any product imported to Pakistan, it needs a lot of red tape and all those diplomatic connections and briberies. And so for any company to bring in a new product, they have to have a surety that if they'll invest this much money to bring in that product, there will be people who will be using it. So they're usually very reluctant to bring a new product in because they know that, the market of these drugs is kind of limited to the amount of investment that they have to make. That's why we don't get these drugs so easily.
I mean, again, as Dr. Agha said, that this medication, once is available, the market will be huge. This will be medication which you can use without thinking too much. I mean, this medication, hardly any contraindication of this medication. And I think you should approach the people who will do some different as a society or as a group, like I think Pakistan Nephrology Society or some other society should approach the government that we need this medication for use and it saves life. Like if blood pressure is not controlled, patient came with the intracellular hemorrhage, I mean, he or she would die from that. There's so many, I think. And not every patient can have or effective labetalol is not going to work with every patient. So I think you need to do something. And particularly, I mean you are in the Army, and I think Army has more.
Even if somebody wants to comment about Army, their screen freezes.
Army ka naam liya, freeze
resources. No, I mean, that's okay. I mean, because
he's not from the Army. Ali Saab is from SIUT. So he's not from the Army. इसीलिए उन्होंने भी ना नहीं की because he knows that he's in power, but he's not from the Army, just to be clear.
Oh, he's not? I mean,
Welcome like an army man to you.
So I can relax now. Okay.
Yeah. तो सर ऐसा है कि the first thing is कि जिस तरह आपने ये दवाई का बात निकार्डिपिन की आपने जिस तरह बात कर रहे थे कि usually for me this is also news. Even while I was in the UK, I don't think we were using this drug at all. वहाँ sodium nitroprusside ही use कर रहे थे before I came back. I mean that was like 6 years ago. That's not too far. So we weren't using this drug IV even in the UK. So I think this forum, I think they भी एक और चीज है कि now that we know that this drug is there, तो फिर मेरा ख्याल है जो भी forums के अंदर जो जिसकी भी है वो हाथ पैर मार के इसको available करा लेगा. Because one thing we have, मतलब आपकी बातें सुन के भी ये चीज तो हमें clear हो गई है कि हमारी armamentarium बहुत ही limited है. और लाहौर में जिस तरह इन्होंने कहा, I don't think IV, जिसमें सर ने कहा, labetalol is available easily. It is IV Lopressor which is available, which is metoprolol. So we have got metoprolol, we've got hydralazine, and we've got isokit. That is the इन तीनों के अंदर से हमें करना पड़ रहा होता है. So one good thing, मतलब directly जो पता चल रही है कि जी एक drug है, very effective, very safe, and we'll see कि क्या किस तरीके से हम जो भी authorities हैं उनको बता सकते हैं कि जी ये तो available कराएं ना.
और दूसरा ये कि nitroprusside pretty much getting obsolete here in USA or developed countries, and it should be very cheap available in Pakistan. It actually has a use. It's a very effective medication, nitroprusside, if you use carefully. I mean, this is a great medication, nitroprusside, and it must be very cheap. So we still the potential for use that medication. So this nitroprusside, but I would say nicardipine is even preferred. So I was told that nitroprusside is available, but it's not available. Anyway,
at SIUT, we used to get nitroprusside. The problem was that we had to protect it from light, and all the tubings had to be wrapped in silver, and it was very cumbersome to give it. And then later on, the availability was also, we didn't get it from the market, so we're not using it now. But I have used nitroprusside, and all these side effects that we're talking about, especially in renal failure with cyanide poisoning and everything, we didn't see any. I mean, we've used it in quite a few number of patients.
Okay, but anyway, so let's move on. So we talk about patient CNS emergencies, what target we should go for. And now we have cardiac, like congestive heart failure, which has very high blood pressure, goes to congestive heart failure, then nitroglycerin, or that is very effective medication. So I'm sure you have a patient who present with dissecting aortic aneurysm. So what is the best medication for that, and what level you want to keep at the target blood pressure would be best for those patients?
I think with the aspect to the aortic dissection, I remember doing my residency, we used to diagnose cases and be excited about it and, controlling the blood pressures in the ICU. But honestly, since it's been 6 years since I've been back in Pakistan, I have not even seen a single case being diagnosed and treated. It's like one of those emergencies in which patient would rather either die or I don't know, Ahad can comment, Dr. Naman Tarif can comment on that. I mean, I have not seen it being diagnosed and treated, especially you're talking about the aortic dissection, So, that's taken to the OR right away, the sending one and all that. So I've never experienced it.
I mean, they must be misdiagnosed, or because this is not an uncommon condition. And I'm sure with Pakistan, with blood pressures not that good control, generally people don't take, everybody takes care of the blood pressure medications.
So it's there usually in units where, cardiothoracic surgeries are happening, cardiology units. Ours is a big one. So there are patients, Dr. Aslan is right in saying there is not a lot of cases that make it to the hospital because they're out of pocket more or less ho raha hota hai. और उसके लिए I mean, you need imaging and you need an echo or at some sort of imaging तो आपको चाहिए कि जी जो patient उसको properly doctor diagnose कर ले तो वो क्योंकि वो tests ही available नहीं होते in time. So that is what he's trying to say. But we do see a lot of dissection at our hospital, Beria Town Hospital, because we've got a huge cardiothoracic service. And usually beta blockade की तरफ ही जा रहे होते हैं. Or if I'm correct in saying that we don't want to give a vasodilator like hydralazine, probably we don't want to give that. That is the position that we need to do.
Absolutely.
Yes, I think most of these patients, they land up in a cardiology setting because of, the shortness of breath or high blood pressure or chest pain. And ideally, you just control the blood pressure to as much possible and plus the heart rate. You just want to decrease, the sheer stress force of the heart.
Absolutely.
The beta blockers.
Most of them, they present with the back pain and blood pressure is low. And also, so this patient, the most important thing is to decrease the heart rate. I mean, labetalol is good medication for those patients if you want to use by itself, although the ideal blood pressure medication, what we use here is ismalol, because ismalol is very short acting, it's a beta blocker, and main goal is to decrease the heart rate to less than 60 first. And we start with the ismalol, and if its heart rate is less than 60, but blood pressure is still high, then we use another medication. In that case, you can use, again, Nicardipine there's no contraindication using Nicardipine with the beta blocker on this patient. So again, you will see Nicardipine can be used pretty much in every condition. Sometime with other medications, sometimes most of the time just by itself. So goal is in aortic dissection to decrease the heart rate less than 60. And then if blood pressure is still not low enough, the target blood pressure is lowest blood pressure you can bring it, but not compromising the renal perfusion. So pretty much 110 systolic in this range, even 105. If the patient has Foley's, patient is making urine. So you want to keep lowest possible blood pressure, like 110, 105 range. If it's a young patient and who has no history of hypertension, at least in that case, some other reason he or she got the dissection, then even under blood pressure is fine. So beta blocker, if you have labetalol, it's perfect for that because it's a beta blocker and increase the heart rate also. Otherwise, if that is not much, definitely, again, as I said, that try not to use strong vasodilator. Strong mean that hydralazine, because it can increase the shearing or pulsatile effect that can increase the size of the dissection. So try to not to use that. Then we
may I make a quick point here?
Sure.
You know, there's this thing, shear stress, that comes out all the time, and I just wanted to kind of make a quick point that this is a mechanical term, an engineering term actually. Stress is defined as two different types of stress. Regular stress is where you're applying perpendicular to the surface on which you're applying the stress. Shear stress is when the vector of the stress is parallel to the surface on which you're applying stress. So when you vasodilate, that increases this stress, the shear stress force on the surface you're talking about. So if you've got a dissecting surface and you're applying shear stress or stress parallel to it, you'll make it worse. So that is why you don't want to use a vasodilator in those circumstances, not use hydralazine or stuff. But beta blockers are good because that would decrease the overall flow and decrease the shearing effect on the vessel wall.
Okay, very nice. So the same, I think that there are some conditions which hydralazine also should not be used, not just dissecting aortic aneurysm, but some other condition also, because of their sheer, strong vasodilator effect. Similarly, a patient has increased intracranial pressure. In that case, it should not be used. And also in a coronary ischemia situation, hydralazine should not be used. Although it's vasodilator actually. So, and it's worked pretty good in patient with congestive heart failure because it decreases the afterload, and in combination with the nitroglycerin, which decreases the preload, it's a very good medication. But what happened that in coronary ischemia situation, because of vasodilation and actually has some inotropic effect also, it increased the oxygen demand or perfusion demand, which actually more than vasodilator effect. So in that case, it increases the ischemia. So it should be avoided in patients who have acute coronary syndrome going on.
Wes, may I ask a question here, which is, I'll appeal to your judgment here and experience, and also to colleagues in Pakistan who have to deal with this all the time. We have the luxury of having 3 or 4 first-line agents available, so we can make a choice. But in certain circumstances, it looks like colleagues in Pakistan may be dealing with a person with a dissection and a high blood pressure, where the only medicine available is hydralazine. We may run into this situation. So at that point, I don't want this preference perhaps to lead to paralysis of action. I think in those circumstances, dropping the blood pressure still will trump the theoretic possibility that the choice of agent may make the dissection worse, but I may be completely out of line. What is your thought? And I'd invite comments, because I don't want to be in a situation where you've got 1 or 2 agents to choose from, and then we talk about negative aspects of those agents, and now we are leading to a paralysis of action where we're not even treating a blood pressure when it needs to be treated. So what are your thoughts on that? And there's no data on this. This is a judgment thing.
Yeah, anybody want to comment then before I have my opinion on that?
Well, I think just have a comment. I think Dr. Irfan might be right, but since I would say easily, if you have IV labetalol available as compared to equal to IV hydralazine, honestly, I use IV hydralazine much more often than not. I don't know, maybe I have a better, sense of control over the patient, but I think from what I'm hearing right now, I should rather switch to IV labetalol, which might be an equally good and available option and more safer. I think that might be a reasonable thing to opt for. I would say because it's an equal opportunity sort of a thing that you can opt for that.
I thought Professor Tarif said that IV labetalol is not available in Lahore. Did I misunderstand?
No, IV labetalol is.
Oh, I see. I'm sorry. I take that back.
So, okay, if IV labetalol is not available, IV metoprolol or low pressure should use it. We should be using that. There's no question about that. There has to be beta blocker first. And if that is not very good blood pressure medication, Loperamide, so in that case, you can add Hydralazine, no question about that, because the gold standard treatment used to be a combination of Ismolol and nitroprusside. And nitroprusside, as you know, that's a very strong vasodilator. It can cause shear effect, it can cause a pulsatile effect, but because it will be damped by Ismolol already, then it is very effective blood pressure medication. So this combination used to be like a gold standard treatment for until we came to other options. So if you have labetalol available, use that. If you don't labetalol, use low pressure IV. Bring the heart rate down to less than 60. If blood pressure is not controlled, then you can use you can use Hydralazine and you can use nitroprusside or nitroglycine or Isokit. You can use that. So, but beta blocker is very important medication in this condition. And Hydralazine not contraindicated if you're using beta blocker already. So you can use Hydralazine also. Very important point. Thanks, everyone. So we have any, I mean, I'm sure there is a patient, you see patient who come with cocaine or other drug-induced hypertension emergencies. You see there in Pakistan or you don't?
Not very commonly in our setting. I mean, not on my side.
Okay, okay. Okay, so let's talk about some patient now. Dr. Rabia, you want to describe your patient so we can talk about, I know it's.
Yeah, so basically it's about a 57-year-old lady who came in with high headache and raised blood pressures for about 2 days. And then the blood pressures were recorded up to 200, 110 at home, for which she had taken multiple doses of captopril herself before arriving to the hospital. For the past medical history, she had 15 or 18 years of hypertension, which was erratic control actually. And then with chronic kidney disease, technically creatinine 1.8 and 2 from last 2 years. So however, that was the first time that she had come to our hospital. So this was all the data that she could, the history that she could tell us. And then home medications were amlodipine 10 milligrams once a day, and then doxorubicin 2 milligrams. That was again once a day, and bisoprolol 10 milligrams, and aspirin and atorvastatin. So that is what she was on. But then again, she was non-compliant to her medicines as well. So on arrival at the hospital, blood pressures were like 190, 110, and then heart rate was about 88 per minute, and respiratory rate was about 16. So on examination, actually there was no neurological deficit, and the heart and the chest were okay on examination. She didn't allow endoscopy, however, we wanted to do that just to rule out the endorgan damage. When we did the labs, actually, the creatinine had bumped a little. It was 2.5. Electrolytes were okay. Bicarb was like 19, a little low though. Hemoglobin was 99.4. So urine to ADR showed some proteinuria, 2+ proteinuria, and RBCs, which are occasional. So echo was simultaneously done, which had 55 to 60% of ejection fraction, preserved DF basically, with trace MR and mitral regurg and trace tricuspid regurg, mild LVH, which probably was because of a long-standing hypertension, uncontrolled rather. So before we saw her, actually, she was already started on levodopa in the ER before she was shifted over to the floor. And then later we added amlodipine to her regime. So that's how it went. So was this a regular emergency that all of us, I believe, we see very often. But then again, we used levodopa as we always do.
Good. So basically, it's easy somehow to put patient on IV medication to control blood pressure, and most of the time we do able to control the blood pressure. But the important thing is how to convert or transition that patient from IV medication to PO medication, right? So this patient, if blood pressure is controlled on labetalol infusion, how would you change to PO medication, and how you transition that to PO medication? That's your next goal will be, right?
Absolutely. Well, actually, I would like to learn more from you guys on that. But then what we usually do, what the practice is so far at my institution, that we tend to start off with oral medication along with the IV, or maybe on the same day, somewhere around the same day. Once we have a better grip of, when better pata lag jata hai ki IV ke upar response kya aa raha hai blood pressures ke. So we tend to start off with oral medication simultaneously, depending on the kidney function and everything. Few people tend to start off patients, medicine tends to start off patients with ACE and ACE inhibitors along with calcium channel blockers at times. But then if there's renal dysfunction, then we mostly start off with amlodipine. Or maybe nifedipine at times. But then with time, we just pull off usually tends to happen the very next day that we're able to pull off labetalol altogether and just switch the patient over to the oral medication, because that's how the practice is, but I don't know the standard, what you guys do there.
Okay, any?
Wes?
Sure.
Wes, I thought the idea of giving IV antihypertensive was to have a controlled drop in blood pressure. But if you start this longer acting antihypertensive oral along with the IV, so probably that control will not have that control. So initially, I think 1 to 2 days, probably IV in those patients. And I'm really glad that the conditions you have talked about in adults, we do not deal with those very often. But we do see emergency hypertension, and we have a similar approach, which you have said. We generally, in the emergency, we have IV labetalol, and then when generally the patient having emergency hypertension, we admit to PICU and go by Nicardipine mostly.
So Dr. Ilyas is a pediatric nephrologist and he's at the University of Arkansas. So Ilyas, do you really see young patient? How young patient you see hypertension?
We actually, sometimes we see neonate also, because if they have a clot or arterial clot or venous clot, but mostly we see patients with who have actually the renal disease. And also we see patients with coarctation of aorta. Of course, you have not discussed about that yet, but we do see patients, but not as often probably as you see in adult population.
So now let's go back to the same question, like how to transition from IV to PO medications. So basically, as Dr. Bia, you said that we have to see what is working for patients. Like we have more choice. So if we start with the Nicardipine drip, and also at the same time, we start with the calcium channel blocker, like amlodipine, this medication. So this patient had labetalol, and you already have started amlodipine, which is fine. I mean, good, but that might not be enough. You have to have something else too with that. So if labetalol is working, so you can change to oral labetalol, which actually is one of the potent antihypertensive medication as far as beta blocker are concerned. And the weakest one is the one patient is already on. This is not very strong blood pressure medication. So what she's on Zabeta. I have hard time generic name. So I would put patient on PO labetalol on this patient while transition from IV to PO along with amlodipine, and see if that works for this patient or not. And if this patient, what's this volume status? Patient is volume overload or euvolemic or was dehydrated? How was the patient? Because she has
she was euvolemic. She wasn't really dehydrated or hypervolemic either, but she appeared euvolemic at that point in time. And as for labetalol, surprisingly, her blood pressures, when I saw her out as outpatient, surprisingly, her blood pressures were pretty controlled on just 10 milligrams of amlodipine. And I think she was just on bisoprolol along without 10 milligrams, I believe. I mean, I thought she would require probably 2 very potent agents to control her blood pressures. But it was just, I thought that she would probably, as outpatient, when she would come back to me, she would probably need something like a regular dose of nifedipine along with a stronger beta blocker, maybe labetalol. But I don't know, it was surprisingly, she didn't, she was pretty fine on amlodipine with the blood pressures of about 135, 80, 138, 139, something like that around on these 2 drugs.
So this patient did not only, I mean, stage 2 hypertension, but maybe stage 3. And so basically this patient definitely needs at least 2 medication to continue. Most of the women, they take 10 milligram amlodipine, they complain of edema. So would like to keep that less than 10, I mean, if possible, to 5 milligram along with another medication, either labetalol or carvedilol, or a patient can stable kidney function, then ACE inhibitor or ARB is not a bad choice. But this patient with the CKD, most of the time they need some diuretics. Even they look euvolemic because their hypertension is to some extent because of probably not clinically, but their volume overload most of the time.
To begin with, when she came in, in one of her prescriptions, we found Lasix furosemide 40 milligrams as a part of her prescription. However, she wasn't compliant to it actually. So she wasn't really taking it. However, as outpatient, yes, she was discharged on 40 milligrams of Lasix again. Yes.
Right, okay. So we can move on to now another very interesting and important topic. Dr. Qayyum, you have a case we can talk about?
Yeah, just before I start, just 2 small comments. One comment is that उसमें थोड़ी सी मुझे जरा confusion आ रही है कि if you can just tell me, so patients in our clinic very often you see once or in clinic एक patient ऐसा जरूर आता है जिसका BP 190/100 होता है, it's 190 over 100, 190 over 110, and he's just sitting in front of you and just talking, and he's just here, and and we know it's not white coat hypertension, because when we ask him that your blood pressure is this much and this, he says हाँ जी इतना ही रहता है, and if you bring it below 160 तो अब मैं बेहोश हो जाता हूँ या मुझे तो बहुत कमजोरी होती है. So I mean, people from Pakistan are smiling, but I know every one of you has seen this patient. We see this patient every day. So my question before I go on to my case is, I mean, what do you do in the US? Because अब वो hypertensive urgency के अंदर तो criteria तो उतर रहे एक तरह से, because ठीक है उसको सामने इस time पे problem नहीं है, but उसके levels तो उतने high हैं. Do you treat it IV or would you just give it oral और say कि जी ठीक है चले जाएं? Because पाकिस्तान में तो ये हंस रहे हैं लेकिन ये सारे oral दे के भेज देते हैं.
Because most of the time I agree with the patient.
मरीज कहता है वो बेहोश हो जाएगा तो उसको आप कहाँ से कुछ और देंगे?
Can I add just one more thing to Ahad's question? This is a very valid question. Ahad, तुमने मेरे मुंह की बात छीन ली. I was going to ask you, this patient comes and they are laughing and chatting with you. The problem is in US, we would refer this patient to the emergency room. The thing is, in Pakistan, we know he's going to refuse and he is not willing to go. That's my question to Dr. Awais. जब मैंने अपने दोस्तों से शुरू में बात करना शुरू की तो मैंने उनको कहा कि यार मैं उनको ना फिर अल्फा ब्लॉकर पे डाल देता हूँ, because I think I need some hydralazine डाल दूंगा, direct vasodilator या alpha blocker, because beta blocker वो ले रहे हैं, calcium वो ले रहे हैं, ACE inhibitor वो ले रहे हैं, thiazide वो ले रहे हैं, मेरे पास options और कोई है नहीं, तो मैं उनको क्या करूं? Number 1, अब cardiora जब मैंने नाम लिया तो उन्होंने कहा ये तो इससे तो mortality बढ़ती है, how do you put these patients on cardiora, why don't you do other alternatives? I told them I don't have any other alternatives. दूसरी बात ये थी कि Dr. West, what is the in US आप जो maximum dose of amlodipine use करते हैं, is it 10 milligrams or 20 milligrams? यानी 10 twice a day या 10 once a day is the max out dose? Because in Pakistan 10 milligrams twice a day is a very commonly used dose. एक तो ये बता दीजिएगा, दूसरा ये कि outpatient person जो कि not willing to go to the emergency, what should be the backup? I usually use Dazocin and send them home basically. I mean, I can't think of a better answer. I mean, but
if I may, I think Dr. Ahad was saying that everybody is smiling. I haven't got a camera on and I was too. But the thing is, this is a very pertinent question, and I will be waiting for the answer of Dr. Nawaz. But what I would do is, I will just put my pen down and just talk to him for a while or her for a while and say, जब आपको मैंने दवाई देनी है ना, तो उसके बाद आपने ये कहना है कि ये दवाई मुझे रास नहीं आई, मुझे कमजोरी हो गई और डॉक्टर ने दवाई चंगी नहीं देती, मैं किसी और को जाना. अगर आपने ब्लड प्रेशर नॉर्मल को कबूल करना है तो फिर आपको अपना जहन बदलना पड़ेगा. वक्त के साथ आहिस्ता आहिस्ता कमजोरी होगी and after 2 to 3 weeks you will begin to accept the new blood pressure as being normal. और जाहिर है उसको what I do is I gradually titrate it towards the lower limit and then come to normal. The choice of drug is different for different people according to indication and the volume status and the renal function. But generally, I think the most important thing is we as a doctor need to tell the patient that you are going to feel weak because your body is acclimatized to the new blood pressure. And probably the counseling is more important than the medication and the targets.
Absolutely.
Well,
so go ahead, please.
Doctor, sorry, thank you. I think everything is right, you know, what our friends have said.
Sorry, interrupting you. Let's make it again. Anybody who give his or her name and just say that one more time, because sometime we cannot see who is talking.
Yes, I'm Noman Tarif. What I'm trying to say is that, you know, most of these patients that we see are diabetic patients, difficult to treat, on multiple medications, non-compliance also, and they have very high blood sugars, and they have never seen a doctor in their like 10 years, and they end up with, you know, high creatinine when you see them. And these are the patients, you know, they are already used to these high blood pressures for a very long time. So they are right most of the time. So I believe them and I don't decrease their blood pressure right away, as Aurangzeb said. So we have to cut it down to, you know, maybe tell them, okay, you know, let's just go to 150 first, and then come down to 140, and then gradually, you know, you go down. So I think this is an approach that you have to take, you know, bringing the patient in confidence and believing the patient's symptoms. That is the most important thing.
Actually, I agree with both of you. The reason being that it happens that when patient has uncontrolled hypertension for a long time, their like brain and kidney, their autoregulation, blood pressure has changed, increased. And if you bring the blood pressure down too quickly, too much, they're going to feel it. But there's no harm in that. If you talk to the patient that you will feel a little bit weak, and if he or she is able to accept that, that's the way it goes. I mean, this is fine to bring the blood pressure close to, not like very low. Like a patient is blood pressure 190, if you want to bring to 130, 140, it's okay. Patient might feel a little bit. If the other approach is also good, you don't have to bring right away to 130 range. You can bring to like 150, 160 range and gradually bring it down. So both approaches are okay, and depends upon how much a patient will be cooperating with you and how much you're willing to accept that. The other thing that, as Dr. Aslan said, that as for the doxazocine concern, there were trials which show that doxazocine does increase the mortality, but if you use only this medication. If you use this medication with medication of first choice medication, then it does not increase the mortality. As long as you are along with first choice medication like calcium channel blocker or ARBs or ACE inhibitor, it's okay to use doxazocine.
And I just wanted to ask one more thing, Dr. Wes, regarding doxazocine. There is generally a feeling of weakness associated with this. People have more chances of postural dizziness and drops with that. So a patient of that sort that Dr. Qayyum said, the patient is familiar with the blood pressure of 190 by 110. Should we start with an alpha blocker when we are already expecting that the patient is going to feel weak when we are going to bring the blood pressure down?
You mean first medication as doxazocine?
Yep. As Dr. Aslan was suggesting, so I was just curious that is the doxazocine is the choice in these patients?
As probably add-on medication.
I'm sorry, Aurangzeb, I was talking about as the fifth line agent actually. So when I was talking about the patient in the clinic, it was somebody on 4 drugs and a blood pressure of 190 that Ahad mentioned. So doxazocine would have been the 4th or the 5th agent.
All right. Yeah. Right, sir.
It's a separate topic, but let me just, obviously everybody knows, but just to, the first line therapy is only 4 medication. There's calcium channel blocker, ARBs, ACE inhibitor, and thiazide diuretics. But on a separate topic, we just spoke about that. We like to have nicardipine available. We can make some effort to available. But at the same time, I was surprised that chlorthalidone is not available in Pakistan. It's such an important medication. Can you folks do something about that? I mean, I'm really surprised that.
Dr. Wes, it was available in combination with the tenormin, that is the atenolol as Tenoret. So chlorthalidone itself is not available, but it is available in combination with tenormin, which is atenolol.
Which is a useless combination, frankly. I mean,
yes.
So if I will available with some ACE inhibitor or ARBs, that would be great, perfect. But with the beta blocker, not very great. So, I mean, you should do something about that. It should be separately available in Pakistan.
Let me tell you something. Hydralazine is only available in 25 milligrams. If you have to put somebody on 100 milligrams TDS or TID, it's going to be 12 pills a day, 4 plus 4 plus 4.
Yeah. So anyway, so for drug of first choice, first like 4, calcium channel blocker, ACE inhibitor, ARBs, and thiazide diuretics. If these medications, you have to start with 1, 2, 3. So if 3 along with diuretics, that is resistant hypertension. So after that, the next drug is basically spironolactone, what we use a lot. Okay, that is the second choice. And then you can also add like beta blocker, vasodilator beta blocker, which only like a carvedilol or diastolic. There's 2. You can add labetalol also, but these are not study much shown that in benefit, but carvedilol. After that, you have to choice what else you to add. I mean, doxorubicin is not a bad choice, but hydralazine is like not even 5th choice. I mean, it's way back. But doxorubicin, if you are using with other medication, it's okay. The other thing that you have to have the side effects. Erectile dysfunction is a very common concern about the patient. Okay, so when you talk about that, and all the medication calls ED, blood pressure medication, all except ARBs and ACE inhibitor, they have not shown that cause ED, but all the other medication. So you have to talk to the patient, all the potential side effect and how you can minimize those. And also, I would try to prescribe medication, long-acting medication, and try to avoid those medication which patient has to take 2 or 3 times a day, like labetalol, like hydralazine. This medication, obviously, the compliance will be low in that case. Okay, so Dr. Had, so let's talk about your patient.
Where did it go?
So yes.
Can you guys see my screen?
Yes.
Sorry, let me unmute.
Yes,
yeah, okay. So my patient is a 55-year-old gentleman who's on dialysis for the last 3 months. He's having his dialysis done like in most Pakistanis do, twice per week. The cause of his renal failure was diabetic nephropathy. He comes to the clinic and reports that, listen, the problem is that in the last 2 hours of my dialysis, my blood pressure just shoots up. When I start my dialysis, it's usually on an average 140/90, but post dialysis, before I'm going home and in the last half to 1 hour, it is 185/105. I look at his chart, his average UF is around 2.5 to 3 liters. He does, as usually the nurses tell the patient, do not take your antihypertensive medication on the day of the dialysis. The patient is not taking them. I do note on the chart that the junior registrar is seeing the patients when the BP shoots up, they're giving them the patient sublingual captopril. I examine the patient. I find that the blood pressure in the clinic is all right. Patient appears euvolemic. He's got a good fistula, which is functioning fine. I look at the medication, essentially bisoprolol, amlodipine, and prazosin combination with some aspirin and some, for mineral bone disease, the patient's on that. And he's on insulin along with the erythropoietin alpha with IV supplementation. So the thoughts are that we do see these patients in our dialysis clinics. The main thoughts are that why would these patients keep on having this intradialytic hypertension? If we can just touch upon, is it renin-mediated hypertension? Do we think that the drugs that we choose get dialyzed out? Another problem, third problem I'd just like to highlight is that dialysis units, because dialysis in the government setup is supported by the government, but if you are having it done privately, everything comes out of the pocket because largely there's no insurance. And there are a lot of dialysis units being run by dialysis technicians, so who obviously don't have a sense of what conductivity is. So what they essentially do is to maximize ultrafiltration till the end. They keep the conductivity really, really high. Even if one wants to think that you are doing sodium profilings so that this conductivity is high at the beginning, and before you send the patient home, you bring it down so that there's no thirst mechanism. At least thirst is under control. The patients are kept at a high conductivity as well. So that is another cause that we do see our patients. And then we see dialyze them at our unit, they don't face the same problem. But that is probably something that we can cover later. But my two questions for the group would be that how, number one, why do you think that these our patients developed this hypertension post-dialysis in the last couple of hours? And if we can just touch upon the medication as far as dialysis is concerned for the junior registrars as well, that, you know, we know now that there are a lot of drugs that do decrease mortality. And yeah, so that is my case.
Okay, anybody have any comments on that? Any? So one question actually. Let me this 2-3 times this question. I don't know. The sublingual captopril. I'm not aware of that. So I remember that like almost 20 years ago, there was sublingual Nicardipine, I think, was available here in US, but that was taken off market because it was dropping blood pressure too quickly and it was dangerous, so it's not available now. So sublingual captopril, I mean, that is used commonly in Pakistan, right?
Yeah, I think everybody would agree that is the go-to drug in, I think that is something that is given to every patient before the nephrologist sees the patient. And that is, at least it's the main worry for me. I think Professor Noman Tarif and our senior colleagues can comment on it, because most patients are on twice per week. And after all, this caputin will cause hyperkalemia. And, you know, so it's always, I'm always scared that I don't know how many captoprils the emergency physician has already placed under the sublingually, and am I due to dialyze this patient right now or not? But captopril, to answer your question, is a very commonly used sublingually.
How many milligram is that dose?
25 milligram.
25.
25 milligram.
Let me ask my
yes.
US folks.
Can I just comment something? You know, it looks very funny and innocent when you say 25 years, 15 years, and we are just smiling over here, all of us. But you know, that's a true fact. And many of our patients, actually, they have a lot of captopril at home. So before they come to the emergency, they have taken probably 5 or 6 captoprils, sublingual, or chew it or swallow it before they land in the emergency. So it's you know, like there's no control in terms of the medication or the management. There are so many factors there that play here. So we have to look at each aspect of these things. But such of these medications like captopril, it's a potent antihypertensive and it does help, you know, sometimes. But we don't use it that often, you know, unless if we don't have available any IV quickly. So we can just give a sublingual or oral chew the tablet, and you know, it does decrease the blood pressure a little bit till you know, you get the other medications ready.
So just want US folks, have we seen ever this medication used here? I mean, sublingual captopril? I doubt it that anybody have seen.
I have not.
We have used in the past IV enalapril called IV enalapril. So that's an IV ACE inhibitor, but not. No,
that's even now we use it, enalapril, yes, IV, but not this sublingual captopril. I never knew that until just 2 days ago that something available in Pakistan. So I can't.
This is Elias. So even AWES in pediatrics, we do not use, although there have been some studies that you can do sublingual Nicardipine, but I don't think any of the hospitals are using it. And captopril, we do not have sublingual. I have not seen that. But as for IV captopril, anaprylate, we don't use in children because there have been a lot of studies with really renal failure with that. We don't use it in the pediatric patients.
Interesting. Anyway, so as for the oral...
May I, Dr. Wes, with your permission? This is Dr. Ali. I'm also a pediatrician. This phenomena that Ahad had described, this post-dialysis hypertension, we see more often in children than in adults. And my understanding for that is that because their vessels and their cardiovascular system is more compliant and is more reactive to ultrafiltration, and that is why immediately after dialysis their blood pressures go up. And what we usually do is that if it is above a certain level that would worry us, we give them 1 dose of imlodipine and 1 dose of Cardase, that is enalapril also, right? Yes. So 1 dose of it, and we'll let them sit for half an hour, and it usually settles on its own. You really don't need to do much as long as they're asymptomatic with that blood pressure. So, and we don't use sublingual enalapril, we just give them orally.
Okay, before you go back to it, let me, PO captopril is available. Actually, this, I think captopril was the first ACE inhibitor available, PO. And we use a clonidine here, like very commonly used, like a PRN basis, like blood pressure is very high, give clonidine orally to lower the blood pressure. So which is not a very good medication to give that. So we try to resident to not to use that, but they say, what is the alternative to that? And what is the short acting medication which can lower the blood pressure without IV, just PO? So one of the first choice we tell them that is captopril is PO, oral, but not sublingual. It's not available here. But again, not used very commonly. So I'm sure that sublingual captopril it works very quickly. So that actually not a good thing, the bad thing, like something works very quickly, drop blood pressure too quickly, that is not very safe. I don't think any safety profile has been done on that. So back to this topic.
Yes, sir, I'm Dr. Kasser. I just want to ask Dr. Ahad one thing. Regarding this patient, did you check the driveway? Because mostly it happens when you remove more fluid. In the end, there is a reflection of the dehydrated vessels, and there is a activation of the system, angiotensin, and there is a high blood pressure at the end. Could it be possible like that?
Okay, so that's a very pertinent the point to make. I think one of Dr. Asma also mentioned that on the thread. So the thing is that this patient was actually euvolemic, so we were not dehydrating them excessively. And your point is well taken. I haven't said actually how I treated this patient, so that is exactly what we do. So the thought process or the mechanism which I would be interested for my colleagues to discuss is actually that once you dehydrate the patient excessively, there is a reflex, increase sympathetic activity, and that is what I mentioned. What I sort of said was renin-mediated hypertension. And we usually treat these patients by giving them losartan potassium 30 minutes before their dialysis sessions, so that we just want to suppress that. I'm not sure if Cardase is dialysable. My understanding was that losartan isn't dialysable that easily, so that is the go-to drug that I use, and I mean to some success with this patient. But yeah, so to answer your question, the patient was euvolemic. I don't think I was ultrafiltrating him excessively.
So in an anephric patient, what is the mechanism of a sudden renin-mediated rebound?
I think that would be a question that I would probably be asking you, Dr. Aga.
Very smart. Okay, so let's talk about this. This actually is a very good topic, and like most of the topics in hypertension, I have given a talk on this particular topic also, and I did some search on that, which is a common problem here everywhere with patient. Like we do 3 times a week commonly, even then we have problem with that. So basically, let's talk about first thing first, whether the patient is taking those medications which are dialysable. So let's talk quickly, which are the medication, antihypertensive medication, which are dialyzed during hypertension session, if that's the reason. So basically, that's also you have to keep in mind when prescribing medication for patient on dialysis, that which medication is dialyzed. So like calcium channel blocker, they are not dialysable. So they actually don't go. Then if you choose between ACE inhibitor or ARBs, ACE inhibitor are to some extent, some 30%, some 40%, some 50% get dialyzed. Well, the ARBs, most of the time as a whole, they're not dialyzed. Well, so very little. It's like losartan, the patient is getting losartan, so chances are that patient will not get dialyzed any. The main thing is beta blocker, because the blood pressure in dialysis patient is very, very sympathetic and driven. Okay, so beta blocker is a drug of choice basically in hypertension in dialysis patient. So some of the beta blocker, they are dialyzed, like metoprolol, they are dialyzed. Very commonly we see that patient is on metoprolol because of AFib or whatever reason to keep the heart rate in control, and mid-dialysis patient heart rate goes up and AFib rate go up. That is because of the metoprolol is almost 90% is dialyzed. So only medication, beta blocker, which are not very little, if any, dialyzed is carvedilol. And to some extent, labetalol also not get dialyzed. All the other medication are dialyzed. So the same contest, if you want to control patient's blood pressure on very cheap medication, you can give atenolol after each dialysis 3 times a week, because atenolol is completely cleared by kidney. A patient on dialysis, patient has no renal function, it's not going anywhere. You give 25 milligram of atenolol, it's going to stay there for 2 days till you get the next dialysis, it's cleaned off completely, and then after that you can give that dose again. So first of all, you have to see whether the patient is getting those medications which are dialyzed and that causing that blood pressure high. That's one thing. But I think it's not very simple. The other thing that there have been a lot of research, actually small studies on this particular topic. They found out that something happens after mid-dialysis which increase the patient's blood pressure. And many of time they've seen that actually they checked patients petrovascular resistant, and they saw that this patient has vasoconstriction at the second part of dialysis. Why this vasoconstriction happens? The theory was maybe increased sympathetic discharge or increased renin activity, but when they checked in a small study, there was no increased renin level, no increased sympathetic level. So they found out actually more than one studies. There's another hormone is endothelin 1 actually. That actually is higher level on these particular patients. And this basically endothelial dysfunction in these patients, and that excrete more endothelin. And that actually is the cause of not all these patients, there are different reasons also, that's not the only reason, but that they found very commonly, those patients has high endothelin level on these patients. So when they go to, and the stimulus for increased endothelin secretion is high sodium bath. A patient is getting like a dialysis fluid sodium is 145, 150. That actually stimulates the release of endothelin and it suppresses the release of nitric oxide. So that's why blood pressure goes high. One of the reasons. I'm not saying more than one reason. Then another reason they found out that the patient who has high sodium bath, increased sodium when they're given to those patients to increase ultrafiltration, that also stimulates the vasopressin. And vasopressin in these patients actually cause hypertension. So these are one of the common causes for intradialytic hypertension. The release of endothelin because of endothelial dysfunction, which happens to some patients, not all the patients. And obviously we talk about that, the desirability of the patient medication. And the third thing that if you're giving patients high sodium bath, these are a few things you can look at into it when patient has this problem. So endothelin is actually first, I think, diagnosed, found out in 1988 or early 90s. And there are a lot of research going on this particular, not very open right now, but if you see the next blood pressure medication, you might see endothelin receptor blocker, because this might be a new blood pressure medication. Next couple of years might phase out because there's no success or may come out with a new blood pressure medication. So they tried many medication which will decrease the level of endothelin. The one medication which stands out is the carvedilol. That medication, it will decrease the level of endothelin or blocks the action of endothelin. So one way to treat these patients is to give this patient change beta blocker. I think bisoprolol that patient is taking, I would give a carvedilol this patient, see if that works. So second thing, that what sodium bath patient is getting. If a patient is getting sodium like 145, 140 even, so bring that sodium down. That also might help on these patients. And obviously this patient, make sure that patient's dry weight is properly addressed. So these are a few things you can do to bring that patient relief from intradialytic hypertension. Any comment or question?
Yeah, I'll make a tongue-in-cheek comment. So essentially, the point to focus on this is that when there is renin release, even in an anephric patient, you still generate angiotensin II, which is a very potent vasoconstrictor. So there is a role to use angiotensin receptor blocker. It's just that it's not going to suck out sodium from the tubules, but it can still cause vasoconstriction. Similarly, there is, and I think, Ahad, you're exactly right. I have seen this happen because the classic teaching is that all hypertension in dialysis patients is volume, right? We are taught to just squeeze them out, squeeze them out, squeeze them out. And then eventually what starts happening is that we take them to a weight which is maybe a little below their true dry weight, and then we dry them out during dialysis, and they have this counter-regulatory surge. Now, I agree with Abbas 100% that that theory, which is actually pleasing and makes some sense, is being put into question when you actually look at their hormone profiles. They're not that out of whack. But in my practice, and I don't do, my first disclaimer is I don't do a lot of dialysis. I'm a transplant doc, so mostly I see dialysis patients when they're in the hospital and only on weekends. But what I see happening is that people dry them out too much, and then you drive the blood pressure high during the last part of dialysis or end of dialysis, and that is an indication for them to drop the dry weight further. Now, we have gadgets like Critline monitors and so on and so forth, so we can actually see their volume fluctuation during dialysis, and that can sometimes help us in figuring out which patient is dry and which patient is not. And in those patients, if you give them a little bit of volume, that helps them. And that kind of sometimes paradoxically takes away that hypertension. So I think that point is very well taken. That's where the art of medicine comes in. You have to actually figure out what their true volume is. And this is usually an issue in, you know, some of our big muscular guys where they're actually holding a lot of volume in their tissues. They look dry, so we sometimes prematurely back off from drying them out. And those are the volumes who've got patients who've got too much volume on them. But there are also those types who are actually too dry, and we are trying to squeeze them too much, and then they have a rebound hypertension episode. So.
Yes, sir. I fully agree with Dr. Aga. Any role of increasing the temperature of the machine to help out this hypertension? And second, I used Zestril 10 milligram for these patients, which is very helpful.
Sorry, what is that?
Zestril. It's AC limiter, sir.
I think it's a lisinopril.
Lisinopril.
That works for those patients?
Yes.
Okay.
The blood pressure. I used calcium channel blocker for them, but no benefit. And then I used this lisinopril for 10 milligram and remarkable improvement in hypertension. And any comments regarding the increase of temperature of the machine? Is there any help from the temperature?
I mean, obviously, you have to go by, you know, evidence-based medicine. There has not been any. It makes sense, and because we treat patient with hypotension with decreasing the pressure, decreasing the temperature. We cut down to 36.5. That makes, so if you increase the temperature, I don't know how it feels to patient, and I have no idea. I have not done it, and I have not seen any studies, but maybe that.
I did, sir. Mostly patients who are hypotensive during dialysis, we used to decrease the temperature, and their blood pressure comes normal.
No, I'm saying that hypotension is treated with the lower pressure, but lower temperature. But hypertension with high temperature, I don't know. I have no experience. I have not gone through any study which has done to use that method.
Right.
Yeah. Again, the lisinopril you're talking about PO, because you have to give, if you try to give medication, I think lisinopril, I don't know how long it takes to work on this patient. So that's the other thing, that some medication, they're ready, they will start working right away. Like if you give clonidine or even PO captopril, but PO lisinopril, I don't know how long it takes. Generally, it takes longer to start working, unless you give sublingual captopril, which I probably will not advocate because
no benefit of sublingual catheter. So one last thing I just want to add, sometimes it is anxious related, tension related hypertension. If you give any anxiolytic to the patient, it will help also.
the other very important question in the chat room, I'm looking at somebody, was this very, very important because they say that sometimes you see the patient, even during dialysis, they keep on eating. They're eating salty food, okay, and they're eating chips or things like this. I don't know how common is that. So obviously that's a very obvious reason for blood pressure to go up during dialysis.
That's one of the reasons.
I'm Dr. Mateen. One more thing that the people used to frequently miss their antihypertensive treatment before the session of the dialysis. If the dialysis session is scheduled to be held in the evening and they miss the antihypertensive morning dose and the evening dose as well. So probably maybe this is one of the factor in Pakistan. We notice that frequently patient used to eat salty chips, nimcos, samosas, and also they miss the antihypertensive treatment before the dialysis.
I think you pointed out, we discussed a few minutes at least, that was a good idea to ask the patient to stop, not to take blood pressure medication day of dialysis?
I don't think so.
I agree with you, but this is very common practice here in USA also. Sometimes, I mean, some patients say, okay, take this medication on non-dialysis days only.
So this is Dr. Aurangzeb, and I just wanted to make a question. So we all agree that this is a real problem and we face it day in and day out. So is there any way to predict and identify for the people? Sometimes it's very hard to decide if the patient is a little towards the drier side or in the euvolemic side and the patient is having that kind of problem. Does it help to know that the patient is having any kind of grade 2 or 3 diastolic dysfunction? And those patients are more prone towards having this overreactive sympathetic system to a little dry weight that is a little drier than they should be. Or this diastolic dysfunction on echocardiography is not really related to some kind of that prediction. Can we relate that?
I mean, if you have echo, a patient's echo, obviously almost all this patient has some cardiac dysfunction. Either they have systolic dysfunction or diastolic, more commonly diastolic dysfunction. And that also can happen that when patient has diastolic dysfunction and patient is volume overload, the end diastolic volume of pressure will be high. And there's also a proposed mechanism that when these patients go on dialysis after a couple of hours, their volume status gets better, then actually their end diastolic pressure actually got lower and their cardiac output increases. And that can also increase their blood pressure. That's one of the many proposed mechanisms for intradialytic hypertension. So your question is whether knowing echo and patient's status, whether the patient has a diastolic dysfunction, helps patient's dry weight measurement. I don't know, but my guess is that if patient has diastolic dysfunction compared to systolic dysfunction, it's easy to take off fluid out because the problem is more congestion rather than low perfusion of the body. Because if patient has low ejection fraction, it's very hard. Patient will be more prone to develop hypotension. So it's hard to take fluid off those patients.
Yes, sir. That was my point. I haven't done any RCT, but we were planning to do something like that. So we were trying to differentiate the patient who were having some kind of even mild systolic dysfunction towards grade 2 or 3 diastolic dysfunction. And usually the pattern is the patients who are having more of a diastolic dysfunction grade 2 or 3, they are prone towards this hypertension on the later part of the dialysis. And those patients who are having systolic dysfunction, usually these are the ones who have to skip their morning hypertensive dose. Otherwise, they are going to feel bad. Thing is, most of the patients in Pakistan, they should be dialyzed thrice per week, but they are dialyzed twice per week, despite of the fact that they are having a serum creatinine clearance of less than 2. So they have to get rid of the same amount of ultrafiltration in 2 dialysis. So this is the reason that so many times the patients are asked to skip the morning dose. because sometimes if the morning dose is taken and they have to get rid of the ultrafiltration, usually they drop in their blood pressure in the later part of the dialysis.
The other question I'm looking at the chat about role of minoxidil. It's again a different discussion. I mean, obviously, minoxidil is a very useful medication in some circumstances, and we use a lot actually in dialysis patient because they are resistant hypertension for many reasons, some of them, and nothing works but minoxidil. So, but minoxidil probably will not prevent the intradialytic hypertension, but interdialytic hypertension or hypertension as a whole, minoxidil is a useful medication in patients who are refractory hypertension, I would say, those patients. But again, minoxidil cause edema, like fluid retention, so make sure that patient get enough ultrafiltration, and also cause reflux tachycardia. And most of these patients, pretty much all, they need some kind of beta blocker to compensate that.
Yes, I have a question regarding minoxidil and end-stage renal disease patients. Don't you think there has more tendency for pericardial effusion in these guys with poor GFR or end-stage renal disease? I would be a little hesitant to use it on a routine basis in dialysis population. What's your take on that?
I mean, theoretically it does, but believe me or not, a lot of patients I'm using right now, if you see at least 10% of my patient, maybe a lot of patients of my patient are on minoxidil. I'm using for a long time, and it's very common medication to be used, and we have not seen pleural effusion or pericardial effusion on this patient, and it works pretty good. Yeah, theoretically it can cause a lot of fluid retention, pericardial effusion, pleural effusion, but we don't see that much.
Okay, thanks.
You're welcome.
Dr. Wes, how often do you use ACE inhibitors and ARBs in ESRD for blood pressure control?
No, I agree with Dr. Aga's comment that these patients, even like bilateral nephrectomy patients, they still have significant level of angiotensin, and then so we use not ACE, ACE inhibitor and ARBs you use, but have a choice between ACE inhibitor and ARBs. We use ARBs because it's not cleared by, it's a long-acting, the once-a-day dose, and most of the ACE inhibitor are twice-a-day dose and also get cleared by dialysis. So there's another topic is very important. I gave a talk recently, how to prevent intradialytic or cardiovascular death in a dialysis patient. So beta blocker and ARBs are very important in preventing that. So from that perspective, also it's an important medication. So pretty much all my patients who needs more than one medication, they are on ARBs.
Yeah, it's not being used as often in Pakistan at all. I'm not sure why, but ARBs is, everybody is on ARB in US basically, but I'm not sure it's not being that commonly used at all in Pakistan actually.
It should be used, it's effective and it's very beneficial from cardiovascular point of view.
Well, that's true. Yeah, please
what
go
is the
ahead,
risk for hyperkalemia in these patients with end-stage renal disease who have a preserved renal function?
I mean, you can see that because in Pakistan they do twice a week dialysis, so you can watch it for that. But we don't see much problem with 3 times a week dialysis, hyperkalemia. And these patients, because they don't have that high level of angiotensin and the kidney function is not already gone, so we don't see much hyperkalemia because of ARBs in end-stage kidney disease. No, I mean, hardly any, very, very few cases. Mostly hyperkalemia. Sure.
It's just one question. Do you have any experience with using fosinopril because it has a dual mode of excretion, renal and hepatic, in dialysis population or end-stage renal disease as such? That appears to have at least a theoretical benefit of not accumulating, so there's no dose adjustment or anything required, and these people seem to be doing well. We used to use that in Saudi Arabia quite a lot earlier on. I don't know what the trend is now for the use of fosinopril in dialysis population?
I mean, you're right. Fosinopril, I think one of those ACE inhibitors which are not also cleared by much by dialysis also. So I think it's a useful ACE inhibitor. So I have patient on that, but I won't say that most common one. But again, many of my patients, they are on ARBs as compared to ACE inhibitor, but fosinopril is a good ACE inhibitor if you want to choose patient on dialysis patient.
So,
How about the use of sorry.
So I just wanted to ask, the reason that ARBs and ACE inhibitors are not that used frequently in Pakistan is because of the belief that it's going to get the residual renal function to a level of no urine output. So what's your...
It's other way around. It's other way around. Let me say it very clearly that actually we give this patient just for this particular purpose ACE inhibitor, because ACE inhibitor has shown to preserve the residual renal function. And this is very, very determined. There's no any doubt on that. Many studies shown that patient on end-stage kidney disease on dialysis want to preserve the renal function, give ACE inhibitor.
Yes, that's
Anybody
true.
who's on PD, I use all my PD patients who are even having like a very small amount of urine. I put them ACE inhibitor, preferably ARB, to preserve the renal function. I think this is this should be the ACEs and ARBs actually protect the kidney rather than hurting the kidney. Even so, once they start on, everybody who starts on dialysis, I may stop their ARB in half of them if potassium is problem before starting dialysis. I sometimes continue ARB even through and through, and they continue this after dialysis as well. But if anybody who was not on ARB, once they start dialysis and they need something, I always use ARB as one of the medication.
That's the...
Yes, I think Aurangzeb has raised a very valid point, and an important point, because we have to understand, as you said, the residual renal function is preserved with the ACE and ARBs. The problem with our patients is many of them, twice a week dialysis, and they have hyperkalemia, most of them. And many of my patients, they're on actually, this Resonium, K-Exalate, because just to, treat the potassium. So they have to take at least, twice or thrice a week. They're not willing to go for thrice a week dialysis, but they are willing to take, the Resonium just to treat and manage the hyperkalemia.
I mean, because of the mechanism of causing hyperkalemia, because the ACE inhibitor ARB is you have to be, if you have better kidney function, you can have more tendency to do hyperkalemia. This patient with dialysis patient, they don't get that much hyperkalemic from these medications. We do have that other medication available in Pakistan. I doubt it, the Petromer and the Localma for hyperkalemia.
No, we don't have those available as of yet.
No, absolutely not.
Oh, nothing.
Even K-Exalate is not, registered. It is kind of, there's no company that is producing it locally. It comes in big bottles, and then, the different pharmacies, they make small packets of 15 grams, and that has been supplied. So it's 40 years now.
It's a cheap medication. There's nothing, they're long there for like 50. There's no reason that it's not available. I mean,
it used to be like less than 100. Now it's, I think, one sachet 15 grams is 750 rupees from my hospital's pharmacy, which is like crazy. It's unbelievably expensive. It's black actually. So.
Yeah. Sorry, on a totally different topic. There's a question on the chat which is asking for whether combining non-dihydropyridine calcium channel blockers with dihydropyridine calcium channel blockers is that clearly it's centrally acting and the other one is peripherally acting. So would you combine? Would you not combine?
anybody has comment? I have. Then I will give my comment. It's called dual calcium channel blocker treatment. Right? That's what you're asking, cardizem and like a amlodipine combined?
Yeah, I think the question is, that is coming from Mocha. Yeah, the question.
Actually, the practice is not very common, okay? And I don't know why. These are two different medications actually work different way. For example, amlodipine or dihydropine calcium channel blocker is very important for many patients. They actually the drug of first choice. But the patient is on cardizem, diltiazem for AFib or some other reason, people think that, oh, you have no choice. You cannot give, amlodipine or nifedipine. But that's not the case. There is no contraindication for patients starting dual calcium channel blocker. The only thing you need to keep in mind that, be careful that it can work as synergistically, okay? Because to some extent the mechanism is same, although it works in a different receptors. So like if a patient has on diltiazem, like 120 or 240 milligram, so start with a low dose of amlodipine, like 5 milligram or 2.5 milligram, and you can raise from there. But there is no reason if you choose to put patient on dual calcium channel blocker to do that. If I have any patient with that, maybe 2 patients with this out of my many patients, not very common. Somehow people think that maybe it should not be together, but there's no contraindication for that.
Dr. West,
Yes,
just one
if you,
question. I'm sorry.
Can I just, if you go through the, the guidelines that have been put forward for diabetic patients with proteinuria, so if you can't use the ACE or ARBs because whatever reason, then diltiazem is given as a choice, and then you add on the dihydropyridine calcium channel blocker. So it's a practice which is quite established and been suggested for last many years.
I mean, the other day I was giving a talk on this, and so there was a question came whether a patient who has history of angioedema from ACE inhibitor, will you give that patient to ARBs or not? So that came out. Okay, so what you guys will do? I mean, you have patient who has history of angioedema from ACE inhibitor. Will you give that patient ARBs?
Yes.
Yes, why not?
Yes, we will be.
Are you giving, or you say you can give?
Yes, we are giving.
Okay, so
maybe sorry, Dr. Mateen here. Maybe we can combine with the dihydropyridine calcium channel blocker with the ACE or ARBs, and not with the non-dihydropyridine calcium channel, because both of the ACE, ARBs, and the non-dihydropyridine calcium channel blockers will cause that of the decrease in GFR. Am I right or wrong?
sorry, repeat your comment. I mean, it's interesting. So you said
actually we can combine the dihydropyridine calcium channel blocker like amlodipine with the ACE or ARBs, but not combining with the non-hydropyridine calcium channel blockers with ACE or ARBs, because both of them, they may cause reduce of GFR.
no, the reason, okay, yeah, you're right. So the reason brought this question whether you will give ARBs or not. So, so there was a kind of discussion came out that if you have a patient who has angioedema from ACE inhibitor, will you give ARBs or not? Because if there is some cross reactivity, there's very little, but still there's a chance that patient will have angioedema from ARBs also. So they were like in a meeting of a hypertension expert I'm talking about. So many said, no, I will not give that. So somebody said, okay, why don't you want to give ARBs? I said, okay, if patient has, you want to protect diabetic patient from proteinuria, if patient has, so somebody commented that, okay, verapamil or non-dihydropyridine like diltiazem also decrease the proteinuria. But the problem is that it does decrease proteinuria, verapamil or diltiazem, but there is no study which has shown that it's renoprotective. So decreasing proteinuria is not the only goal. Basically, renal protection is the goal. And there's no study shown that verapamil or diltiazem would cause renal protection. Although it does decrease the proteinuria to some
Well,
extent.
that's why you need to have a controlled blood pressure, So you use the verapamil or diltiazem, and then control the blood pressure with whatever, combination you want, like dihydropyridine, calcium channel blockers, diuretics, and whatever.
Yes.
Dr. West, can I ask one question? I'm not sure if I'm correct, but just wanted to ask you. So the question is, non-dihydropyridine calcium channel blockers are independently weak antihypertensive agents. Is that statement correct?
Very
Oh, and then sorry?
very weak. It's almost
Exactly. So my point, exactly. So my point is, I mean, when you have somebody on Diastolic or verapamil for some other reason, so to consider that as an equal antihypertensive agent may be wrong. Number two, my question is that are ACE inhibitors or ARBs relative to the other class of antihypertensive are weaker, sorry, are still weaker antihypertensive agents? Is that correct?
Mute himself or herself.
I'm sorry, the RAS blockade is, the category is in maybe something which is not a renin-induced hypertension is considered as a weaker antihypertensive agent.
Okay, so it's a long discussion, but here's the thing that hypertensive patient generally, they are divided into two kind of hypertension. One is low renin hypertension, which is salt sensitive hypertension, and one is high renin hypertension, okay? So people who have high renin hypertension, for those, the ACE inhibitor or ARBs are very potent as calcium channel blocker or as a blood pressure medication. Who are those high renin hypertension patient? Basically as a whole, like a younger patient, okay? Those are basically have high renin. So if a patient comes to you like 30-year-old, 25-year-old, and he or she has high blood pressure, and if you give them ACE inhibitor, it'll be as potent as calcium channel blocker for them. To some extent, a patient who has end-stage kidney disease, dialysis patient, the potency is much lower as a medication blood pressure. But these are much stronger than verapamil or cardizem, diltiazem. Diltiazem and verapamil as a blood pressure medication are very weak, almost useless.
Not so uncommonly, you see a lot of people with diastolic hypertension. Somebody coming to your clinic with 140, 100, 140, 105, 140, 110. You know, so their systolic is not a problem, but diastolic hypertension is a big problem. Any recommendations for such patients? I mean, I've been struggling with such patients actually.
Yeah, luckily they are not, there must be a younger patient because I've seen that those older patients, older more than 65, they always have systolic blood pressure very low. Actually, they're systolic. They have systolic hypertension, not diastolic. But younger patient, you see, they have diastolic hypertension. People have used, say, maybe verapamil or beta blocker on those patients, but has not worked. So again, you're back to same, either ACE inhibitor or calcium channel blocker.
Thank you.
And let me see any other question. So should we call it a day or any other question?
Dr. Bali here. Sorry, I wanted to ask a question. You sometimes find patients who have got very low diastolic blood pressure. I mean, their systolic is high, but the diastolic is low. So what sort of targets do you want to achieve in those? Do you only target the systolic, or do you have to keep diastolic above a particular limit so that it does not affect the renal perfusion?
I mean, that's a very tough question, but again, you have to consider the diastolic hypertension also, because you know that the diastolic pressure is the pressure which causes the cardiac perfusion. Okay, that if your diastolic pressure is too low, that is not good for cardiac perfusion, and that patient will long term is going to hurt the cardiac perfusion, and so you have to. So in that case, you just have to be mean blood pressure. You have to maintain that. In that case, you have to go a little bit high systolic blood pressure. So if patient comes with this diastolic blood pressure of 45 or 50, and systolic blood pressure is 140, which is again a bad, sign anyway to begin with, but you have to tolerate a little bit high systolic blood pressure in that case, if that can increase the diastolic blood pressure.
I think diastolic below 60 is compromising the coronary perfusion. So diastolic, you have to keep it around 60 or plus, because otherwise compromises the coronary perfusion.
So regarding the case of Dr. Ahad, is there any role of anxiolytics in that patient to control the blood pressure, maybe because of sometimes there is anxiety of the patient? Possible?
No study has worked. Again, we're talking about, you can try different things. But again, there's no, study on that using anxiolytic on patient who had interdialytic hypertension. Maybe the people who staff who are taking care of those patients, they might need something, but.
Right.
Okay. Dr. West, I wanted to ask a question. There were few patients who were having some kind of idiopathic mild shortness of breath along with hypertension, and they were on drugs, and they were fairly controlled too. They were having a diastolic dysfunction of grade 2 or 3. And with discussion with some cardiology colleagues, they were shifted to hydralazine and isosorbide mononitrate, and they got better in terms of the symptoms. So what's your suggestion? Do you use hydralazine as an antihypertensive medicine? Because in your previous talk, you were telling me that it was something like a sixth or seventh option, hydralazine. Do you think of any patient in terms of any cardiac profile or finding on echocardiography where hydralazine may be higher up in the options along with the isosorbide mononitrate without any indication for any anginal symptoms that I am talking about?
Hydralazine as a pure antihypertensive medication comes the last at the end. Okay, all the medication, then the gap, then comes hydralazine, and I can come back to the reason for that. But the use is hydralazine, which is has proven value, is a combination with the isosorbide. Is patient who had congestive heart failure, and in America, this has been on blacks. It has shown benefit and longevity because obviously combination, it decreases your afterload by hydralazine and preload by isosorbide. So it comes as bifid. This is a one medication tablet contains both. So that definitely is as good as ACE inhibitor ARBs as for the benefit concern for congestive heart failure patient. But blood pressure is not good at all because of many reasons. First of all, it's very short acting. And the second thing that it has tachyphylaxis effect, its effects goes down slowly. And the third thing that if you give more than 150 milligram in 24 hours, after that, it's very commonly has some side effects like rheumatism or even drug-induced lupus and other things. And we actually published a case last year, 2 cases of vasculitis, hydralazine-induced vasculitis. So not a great medication otherwise for blood pressure only.
Especially with the reduced, it is basically the study that you're quoting is for the reduced ejection fraction.
Yeah, as well. Yeah, thanks for correcting me. This is not for diastolic blood pressure, diastolic dysfunction, it's for systolic dysfunction. Actually, diastolic dysfunction is heart failure is a problem. There is no medication up till now which is beneficial in those category. There's no medication. And it's very common. It's a 50-50. Like if you see all patients who are congestive heart failure, it's a 50% would be probably more. As the population is growing, the older patient, they have more diastolic dysfunction compared to systolic dysfunction. Even now the Entresto, this is indication for systolic dysfunction. Now they're coming out with some study that is beneficial in diastolic dysfunction also, but so far those findings are not very impressive. There's no medication which is better or improves for diastolic dysfunction, which is a problem. Okay, let me see if in chat room anybody has any question. In patient with scleroderma, renal crisis, rising creatinine, would you use captopril? Absolutely. So this patient, scleroderma, renal crisis, there's no medication works better than ACE inhibitor. And you might have, transient increase in creatinine, forget about that. The benefit of, you'd have no choice other than giving patient ACE inhibitor in that case. Yes, I would.
Actually, I had patients, coming off dialysis with a renal crisis, and we started him on captopril, and gradually, slowly we saw, the function resuming back. He was off dialysis.
So he was on a scleroderma renal crisis, or just?
Yes, scleroderma crisis patient.
Yes, absolutely. It's a very, very clear indication that the patient should be on ACE inhibitor. Okay, so any other question, any other comment before we say good night? It's already, I think, past midnight in Pakistan, right? Hello. Okay. Then it's Khuda Hafiz, Shab Bakhair. Good night.
Okay, sir. Thank you very much. Thank you.
It was
Allah
wonderful.
Hafiz. Yes.
Allah
Allah
Hafiz.
Hafiz.
Thank you very much. Thank you, Hafiz.
Thank you, everyone. It was awesome.